What is an amblyopia? There will be some 5 to 6 critical points in the topic of amblyopia which you have to remember for entrance exam and also for university exam. So, amblyopias are a partial loss of the vision in one or the both eyes without any organic disease in the ocular media. That means, suppose if somebody is unable to see because of a cataract, you don't call it as amblyopia. If I am having any conjunctivitis, if I can't see, we don't call it as amblyopia. In the absence of any organic disease in ocular media, if I am having any retinopathy, if I am unable to see, you don't call it as amblyopia. And there is no organic disease in the visual pathway. My optic chiasma, lateral geniculate body, everything should be normal. In spite of all that, if I am unable to perceive an image, then you call it as amblyopia. So how does amblyopia develop? Why the brain stops interpreting an image and lead to the loss of vision in amblyopia is an important question. If you look at our visual development, what is the critical period, doctor? It is from the birth to 6th year of our life. The most sensitive period out of this is our development in the first 6 months of life. So that is the reason amblyopias don't develop after 6 years. Whenever they appear within the first 6 years, because the first 6 years is the most critical period for the development of the vision. So what are the amblyogenic factors which will make the retina, which will make our visual cortex stop perceiving a retinal image and lead to visual disturbance? So what are such factors? Number 1, any visual deprivation. If one eye is able to see a particular image, but the other eye, due to hypermetropia, is unable to see the image, then automatically the eye which is normal, only it will start fixating the print in the book whenever the child is reading. That eye which is hypermetropic, it become lazy. It will say, anyway I can't read this, why to do it? The other fellow is there, no? Just like in the hospital postings. He is there, no? He will conduct all the deliveries. Then why are you there? I am here to sleep and read PGV entrance books in the labor room. Don't do that. Don't do amblyopic hospital posting in a housemanship. Forever you remain amblyopic. Because the critical period for the development as a doctor or a clinician is housemanship. So we should not become an amblyopic guy. So, visual deprivation which can occur in anisometropia. What is anisometropia? One eye is emetropic, other eye is either myopic or hypermetropic, then you call anisometropia. Any deprivation, suppose unilaterally only one eye is having a congenital cataract, then that eye will start feeling lazy. I don't want to fixate whenever I have to look at an object. Let the other eye which don't have cataract do that job. Then any abnormal binocular interaction. If one of the eye is having esotropia or exotropia, then only the normal eye keep fixating, the esotropic or exotropic eye doesn't. In long run, amblyopia will be developing. So what are the different types of amblyopias? Typically, we have a strabismic amblyopias. Whenever there is a prolonged uniocular suppression in children with a unilateral constant squint, then they will be developing amblyopia. Then if there is any congenital or a traumatic cataract in only one eye, or if there is any complete ptosis in one eye, or if there is any dense central corneal opacity in any of the eyes, only one eye, then there is a deprivation. It stopped actually perceiving the imagery and visuals. So stimulus deprivation amblyopia it is called as, which is also called amblyopia exanopsia, was the older term. Then any refractive error which is more than that of the other fellow eye, then that fellow eye only will be working and this refractory error containing eye will stop working, which is called anisometric amblyopia. Now comes doctor, there are two kinds of refractory errors: hypermetropias, myopias. Hypermetropic anisometropia is more likely to lead to an amblyopia than a myopic anisometropia. If one of my eye is having hypermetropia with the other eye emmetropic, then I have a greater chance of developing amblyopia than my one eye having myopia with the other eye being normal. So even 1 to 2 diopters of hypermetropic anisometropia can lead to amblyopia, whereas 3 diopters of myopic and anisometropia is required before the amblyopia develops, is what you have to basically remember. So anisometropia, if significant, can lead to amblyopia even if the refractive power difference between the two eyes is more than 2.5 diopters if it is myopic. But if it is hypermetropic, even 1 to 2 diopters is sufficient, is the point you need to carry. Now doctor, why anisometropias should lead to development of the visual suppression? Very simple. Whenever we have anisometropia, that is one eye is having either myopia or hyperopia, other eye is emmetropic, then the size of the retinal image which is perceived is different between emmetropic and anisometropic eye, the size of the retinal image. So this discrepancy in the size of the retinal image is basically called anisoconia, and if up to 5% of the difference in the size is okay. If it is more than that, then obviously that particular eye which is receiving a smaller image will say, why to fixate? The other guy is anyway receiving full image, fully blown, no, let him only see, I won't see, it will say. Then isoemmetropic amblyopia is another important type. Suppose if there is a bilaterally high refractive error, then that can lead to a bilateral amblyopia. When big images are coming, it is like watching a movie sitting in the first row on a Saturday evening where the movie theaters are very busy. Can you appreciate a full-blown hero-heroine dancing? So when both the eyes are highly hypermetropic, then the images falling are so big that I can't see the movie. I love to listen the voice and enjoy the dialogues rather than movie. Then if there is any astigmatic refractive error in one of the eye, let us say one eye had corneal irregularities leading to astigmatism, other it doesn't have, then that can lead to development of a meridional amblyopia. And what are the important characteristics of a amblyopic eye? So once more, let me re-emphasize to you, doctor. Amblyopia is a loss of vision with a normal media, normal retina, normal visual path. In spite of that, either due to sensory deprivation, etc., which we discussed, one of the eyes is becoming lazy. That is the whole problem in amblyopias. So, in the amblyopic eye, the visual acuity is reduced. In the visual acuity, we have two types: recognition acuity, resolution acuity. As the names itself imply what they are. So recognition acuity is more affected than resolution acuity. Whenever there is a loss of visual acuity in amblyopia, then a very important test is called as neutral density filter. So what does it mean to say? If you want to differentiate a vision loss due to amblyopia versus patients who are having a vision loss due to an organic lesion, then we use what is called as neutral density filter. So whenever you use this neutral density filter, the visual acuity will be further decreasing if the vision loss is because of organic lesion. But the visual acuity will be same or improving if you use a neutral density filter if it is due to amblyopia. So amblyopia versus organic lesions, if you want to differentiate, the best way to do that is by using the neutral density filter. Basically this filter, what it will do is certain particular spectrum of the visual field, it will basically cause enhancement and attenuation. So when you use such a filter, amblyopic eye will remain same whether you do any kind of alteration, but organic lesions it will further decrease if you use a filter. So that's a differentiator. Then a very important phenomena is called as crowding phenomena in case of amblyopias. So what is crowding phenomena? You can check a visual acuity using a Snellen chart. You can also use by single letter type of charts, optotype they are called as. Visual acuity is much lesser when you test it with a Snellen chart which has multiple letter charts than when you test it with a single chart, which is called as crowding phenomena, which is very classical in case of amblyopia. Then there will be a fixation pattern which can be central or eccentric. So typically if one eye is having myopia or hypermetropia and the other eye is emmetropic, then the place where the image is falling in one eye is different from that of the other eye. So the other eye, which is basically fixating, the amount of eccentric fixation happening in the other eye is an important measure of the degree of amblyopia. Then how is the color vision? Usually it is normal, but in deep amblyopias with the vision below 6/36, then even the color vision also get affected. Color vision is mainly by the cones. Cones are highly dense in the central part of the fovea. So that's the reason normally it is not affected, but severe amblyopias even color vision is also affected. So how do you basically treat amblyopias? Classically, it should be started as early as possible because the first 6 months is most important period where the entire visual fixation is developing in a newborn child. So what is the rule in amblyopias? Younger the occlusion therapy, better will be the prognosis is what need to be remembered. So what is an occlusion therapy basically? One eye is normal. Whenever the person is looking at an object, only it is fixating. And the eye which has become amblyopic is lazy and not doing anything. So what will you do? You will also give it work. You will also give it work. Just like in our mathematics class, some of our classmates, the moment maths teacher tells a problem, they used to raise the hand and give an answer. And few guys like us used to first of all decide whether it is a tough problem, easy problem, is it worth investing brain on this or not. वो सब decision होने के बाद then we used to try to understand problem which we never used to understand. So all the lazy guys used to encourage the brilliant guys. Very good. Come on, next question, you only answer. So normal eye has become like such a meritorious student in a mathematics class. Only it is fixating for every question. Lazy eye remaining lazy. So you occlude that. You tell all intelligent guys go to section A. All dullards sit in the section B. Then section B may once more activity will start. So occlusion therapy, amblyopic eye ko you will be forcing to start working and fixating. That's what you will be doing. But before you start occlusion therapy, what is the most important thing that you need to do? Is there any cataract? Why that eye became lazy? Why that student is not answering? You need to check. So, if there is any cataract, treat it. If there is any refractive error, treat it. Then only you do the occlusion in the normal eye. So, spectacle correction should be done before 6 years of age in cases of the amblyopia due to the squint. Because by the time it is 6 to 7 years, the visual maturation will be completed. Now, doctor, what is the schedule? How long you need to apply a patch on a normal eye and make lazy eye to start working? Typically, up to 2 years. We use a formula 2:1. That is 2 days in the sound eye and 1 day in amblyopic eye, we apply that occlusion patch. Because if you occlude only the normal eye forever, then that can become amblyopic. Even that can become lazy, no? If you say you are reading very well, go home, you don't need school at all, then that is bad for the brilliant guys also. At the age of 3 years, 3:1. What is that? 3 days in sound eye, 1 day in amblyopic eye. At the age of 4 years, 4 days in sound eye, 1 day in amblyopic eye. Similarly, 5 years, 5:1, 6 years, 6:1. So for an infant who is under 1 year of age, you need to patch the good eye 3 to 4 days full time and amblyopic eye for 1 day. And you basically need to repeat this pattern continuously. So this is the typical protocol of 2:1, 3:1, 4:1, 5:1, 6:1. But this is the most recent protocol, which you can remember because in entrance they can ask it. Now, how long do you need to continue this treatment? Obviously, the parent will be asking you this question. Until the visual acuity develops fully. Until there is no further improvement of the vision for 3 months, you need to basically do this occlusion. Either of these two criteria satisfied, you need to continue the occlusion. Now, how will you know? Okay, sir, you are applying occlusion. How will you know that the amblyopic eye is improving or not? Slowly it will wake up and start fixating. You take the object to a particular side, then it will start looking at it. You take the object some other side, it will start looking at it. The moment this lazy eye started doing this, then there is an improvement in the visual acuity. Then until then you need to do the occlusion therapy. So that's all the story, doctor. Any question on amblyopia, now you must be equipped to basically answer. Yes. Please check Dr. Gaikwad has a little problem in transmission. Most of them, if there is any problem in transmission, it is because of your local internet speed. At least 1 Mbps you should fight with your internet service provider and get it dedicated 1 Mbps. Then you have the teacher anywhere in the world, Australia, North Pole, South Pole or Antarctica can reach your home. That is the power of the internet. But you need to ensure that at least 1 Mbps is a minimum courtesy speed which is basically required. Please ask, please help them to how to check, because there are some new students, so they should not have a struggle. They may disbelieve the technology itself because of a foolish internet connection. So just request them to check their net speed and then help them out. Huh? Raju, just chat with them. Yeah. Toxic amblyopias. 1-2 comments about each of them. Tobacco amblyopia, heavy, especially pipe smokers who also drink. There is a greater chance of toxic amblyopia. Because if they drink also, then B complex will be low. Hence it is called tobacco alcohol amblyopia. Now in tobacco, what is the important substance leading to amblyopia? It is the cyanide which is leading to it. And usually it occurs between 40 to 60. And there is a fogginess and difficulty in working for the near objects. Then what is a very important type of scotoma which you see in tobacco amblyopia, doctor? One of the favorite MCQs of the examiner. Ceco-central or centrocecal scotoma. And for the red color, it is much more bigger defect than the white color is also what you need to remember. Then what is ethanol amblyopia? It usually occurs along with tobacco in the heavy drinkers, especially who have chronic gastritis. And one of the ways it can lead to amblyopia is ethanol will lead to the vitamin deficiencies with peripheral neuritis. Same myelin sheath problem can affect even optic nerve, leading to associated optic neuritis is what you need to remember. But more than ethanol, we are worried about methanol. Methanol can lead to development of an acute amblyopia with a significant optic atrophy and permanent blindness. Quite often we listen, there is adulteration in the liquor and the whole village men lost their eyesight. It is the methylated spirit which is the one responsible for that. Adulteration is what need to be remembered. So, sometimes methanol is used as a solvent in the industries. Any inhalation of that solvent also can lead to visual loss. And methanol is metabolized very slowly in the body. What is the main toxic substance in methanol, doctor? Methanol is oxidized to formic acid, which typically convert into formaldehyde. Ultimately, it is the formaldehyde which is responsible for the loss of the vision. Favorite MCQs of the examiner. Then which part of the retinal cells are affected? Another common MCQ. Ganglion cells are the ones which are affected due to the toxic effects of the methanol. And it can also lead to optic atrophy. And there can be a characteristic odor due to the excretion of that formaldehyde. We will anyway read it in more detail in our forensic medicine is all about poisoning others. Then quinine amblyopia. Even small doses quinine in susceptible guy can lead to development of idiosyncratic way, not dose related, can lead to development of the amblyopia. If you examine fundus, one important feature in quinine amblyopia is the retinal vessels will typically become attenuated and contracted visual fields is what you typically come across. Then which anti-tubercular drug can lead to an amblyopia, doc? Ethambutol. Ethambutol can lead to a toxic optic neuropathy, and especially if a person is alcoholic previously or diabetic previously and had tuberculosis and now receiving ethambutol, more vulnerable to develop ethambutol associated amblyopias. It is a central scotoma, classical of ethambutol amblyopia, and it can lead to bitemporal hemianopia, ethambutol toxicity. And they will also have impairment of color vision also because of the central scotoma. And if you look at the fundus, there may be signs of papillitis, but most of the times the recovery will be there if you stop ethambutol with an early recognition of the toxicity is at least a good news about the ethambutol. So this is all the story of amblyopias, doctor. You need to be very, very sure when you go to the tomorrow's exam.